Thank you, Sean. And thank you for those warm applause. And thank you, HCCA, for coming to the National Capital Area this year. As you may have heard, budgets are tight for the federal government, and it's especially tough for those of us in the federal family to travel these days. So it's very, very helpful for not just me, but for others in our office and our federal partners to be able to come almost down the street and be able to join you. And I think it is so very, very important that there be a federal presence at HCCA as much as possible, because everything that we're going to accomplish together. And we can't do that from a distance. We need to have the ability to be able to join with you. So I'm especially happy to be with you here in our neck of the woods. Our first slide is a serene slide. And I'm following up a little bit on where we left things a year ago in Las Vegas when we talked about how stressful a healthcare compliance officer's job is. We discussed that there had been some survey work done rather recently that indicated that there were high levels of what I call negative stress. There's positive stress, the kind that makes you get up in the morning and want you to accomplish your job. We're talking about the kind of negative stress that occurs when you don't feel in control enough of your environment, and the people that you need to work with are not listening, are not an important part of important objectives that you're trying to accomplish. And it was somewhat dispiriting to see that there's still surveys out there that indicate that indeed stress is as great as it ever was in this field. And so I wanted to at least start. After all, if you're going to spend your first 30 minutes of a Monday morning with the Inspector General, I'm not quite sure that necessarily is the best way to have a stress-free day. So at least I was going to start with a serene slide, but it's more than that. We're going to make it something of a maritime theme this morning. I said National Capital Area a few minutes ago because we're not actually in Washington, D.C., we're in Maryland. Maryland's a small state, but it's noteworthy in a couple of key respects. One is that there's a lot of water. It's the home of the Chesapeake Bay. In fact, if you like crab cakes, this is the place to have them. It is the home of the U.S. Naval Academy up in Annapolis. And if you can stay around the area for a while, the Academy has a terrific exhibit right now on the bicentennial of the War of 1812, which was mostly a naval conflict. A lot of it occurred here in the state of Maryland. Next year will actually be the bicentennial of the bombardment of Fort McHenry and the Star-Spangled Banner. So water is very important. It's a small state, but a very, very long coastline. Maryland also is a very prominent healthcare state. I mean, like other states, it has major hospitals and research institutions, but it's also where key operations for the Centers for Medicare and Medicaid Services are located up in Baltimore. It's home of operations for the Food and Drug Administration, the National Institute of Health. It's very much of a healthcare state. So I wanted to combine our maritime theme here to take advantage of the fact that we're surrounded by water, and we're going to take a voyage this morning towards our objectives in the healthcare transformation that's occurring. We know that we're headed in the direction of a more efficient and effective healthcare system. And people have talked about the change in the landscape. The benefit, of course, of a landscape is that sometimes you have landmarks. So you're better able to figure out where you're trying to go. When you're on the water, navigation becomes very, very key. And it's not necessarily obvious where you are. I mean, this is a serene slide as long as you know where you are, but if you're in the middle of this water and you need to get somewhere and you don't have the tools, this can actually be a very disturbing slide. But I want you to think of our journey this morning as a voyage in a general direction towards getting greater efficiencies and effectiveness from our healthcare system. And that's going to focus on patient-centered care. This slide does not show any healthcare provider. It's actually a slide of a passenger-centered ship, one would hope. But what I'm doing here is taking advantage of the idea of a service that is directed towards those who are supposed to take advantage of that service for their benefit. So indeed, and this is the kind of metaphor that has been used very effectively by John Bogle, the founder and longtime chairman of the Vanguard family of mutual funds. John Bogle, who always called his employees crew members, because he viewed it really as a voyage of discovery on how to get value out of investments. In fact, if you've seen the Vanguard trademark, it's actually a picture of a turn of the 19th century battleship. And his view was the crew exists for the benefit of getting maximum value for the investors and the shareholders. The notion of this ship, of course, that's pictured is to make for as comfortable and safe a ride for its passengers in the course of getting them to their destination. What we see in healthcare is that our healthcare enterprise is not very effective at being able to maximize value for those who get on the enterprise to take advantage of the services that are offered through our otherwise very, very impressive advanced healthcare system. We don't want a ship that goes around in circles, that goes into dangerous waters. We need a healthcare enterprise that is directed, that's going in the right direction, that's doing so safely. And it's so critical that we think in terms of a compliance function that helps make that possible. The compliance function is going to change as a result of this more sophisticated thinking about getting a healthcare enterprise moving very definitively in the direction of greater efficiency and effectiveness. This is a significant change driven in large part by healthcare experts who've found over the last 5 to 10 years that we can deliver healthcare at a savings of anywhere from 20 to 30% or more of current expenditures. The healthcare system expends about $2.7 trillion. Our experts say that you could cut that by almost a third in many circumstances and still deliver the same care. So that's a tall order, and it's not as if healthcare providers have not thought of themselves as patient-centered in the past. It's just that our knowledge of healthcare and medicine has moved on, and technology now allows us to measure things that we couldn't measure before. So we need to take advantage of these new findings, these new ways of doing business, and compliance is going to be a very critical part of it. Think in terms of a traditional treatment plan in which a compliance officer might have looked to see whether the plan is dated and signed. Now think in terms of a more clinical compliance operation where it would be important to look at the plan and see whether it has concrete, measurable, observable goals and objectives that actually serve the needs of the person who's receiving the services. A more sophisticated exercise. And indeed, I do think the compliance function will be headed towards those kinds of more complicated functions. We need to chart that destination towards quality and cost effectiveness. And we have one person on the bridge, but it's going to take a whole team of people. We're going to need to think in a very cross-disciplinary way. Perhaps we did so in the past to a certain degree. We need to double down on the idea that we really need to cross disciplines far more effectively than we did in the past to make sure we're headed in the right direction, and that we do so keeping close account of the need to always ensure passenger safety, patient safety, passenger quality, patient quality, to get us to our destination. There are always vulnerabilities that we need to think about, that we need to have on our screen. This particular slide has an accompanying slide which should reduce the stress that's caused by that slide. You know, it's April, and every April for 100 years, people who have occasion to see an iceberg think about the Titanic. Last year, you might remember, was actually the centennial of the tragic sinking of the Titanic in April of 1912. The story is well known. 2,200 people were on the ship when it made its maiden voyage from England to the United States. During the course of an evening, about 4 or 5 nights in, the Titanic hit an iceberg. Over the course of an hour, hour and a half, it sank. There were lifeboats on board, but not enough to save anywhere near the full number of passengers. Out of the 2,200 that were on the ship, about 700 survived. At this point, after more than 100 years, you'd think there would be nothing new to say about the Titanic. But actually, there's some late-breaking news. And the news concerns Safety Officer Maurice Clark. The notebook of the safety officer who needed to certify that the ship was seaworthy just before sailing out of England. His notebooks became available just last fall and went up for auction in London just this past November. And for the first time in 100 years, we learned that Maurice Clark, in deciding whether he could certify that the ship was seaworthy, he was a government employee, wrote in his notebook that he thought that the ship should have more lifeboats. He recommended that the ship have 50% greater capacity with lifeboats. It left England with 20, and those 20 lifeboats, at least in theory, should have been able to rescue about 1,100, about half of the 2,200 passengers. He recommended that there be 30 boats put on the ship. His thinking being, and this was common at the time, that because the sea lanes were rather well traveled, it would be a matter of trying to ferry people from one ship to another. But that if you had to ferry 3 times over with only 20 lifeboats, panic could ensue. So he thought it was a good idea that more lifeboats be added. But the White Star Line, which ran the Titanic, apparently said, no. And this was indicated in his notebook. He said, I was fearful for my job. I received indications that this would not be possible. What in effect happened was White Star said, how many lifeboats are necessary? What does the law require? At the time, the law, which dated back to the 1890s, based on tonnage, required 20 lifeboats. So White Star Line, in effect, said to the safety officer, we've met the requirements of the law. We need to get going. And sure enough, Maurice Clark certified the ship as seaworthy, even though he knew that there weren't enough lifeboats. And in the inquiry that followed the sinking, in all the testimony, he never indicated otherwise. We've gone for more than a century with the closed confidential notes of Maurice Clark not available. And one can only imagine if there were more lifeboats, and of course, it wasn't handled especially well that night. In theory, a lot more people could have been saved, but certainly Maurice Clark's failure to follow through on what he saw resulted in unnecessary deaths of hundreds of people. There's a story in there that I think is worth considering as we move towards bulking up, reinforcing the compliance function, and understanding that it's very difficult at times for the law to catch up with technological and other developments that occur. And it's very important to stay focused on quality, safety, the effectiveness, irrespective of what any particular landmark law might require at any particular time. This is the one slide I have that shows a lot of ships. And I could spend the rest of our time together just talking about the importance of coordination, because so much of this evolving era has to do with creating a more coordinated care system across providers, physician groups, acute care, post-acute care institutions. I think of just how significant it is that we have an opportunity to have compliance officers from so many institutions getting together at this Compliance Institute. Sure, to hear from speakers, but even more important, to talk among yourselves, because cross-provider compliance is the future of healthcare more and more. You don't necessarily see it right now in many corners of the country. I think it's estimated that various coordinated care models right now are in some form, perhaps in 10% of our healthcare environment. But the handwriting is on the wall. It's so important to be thinking across different providers. And everything that we do, I think, from a government perspective, requires us to think about how important coordination is. For example, when it comes to the whole notion of accountable care organizations, and the notion of Medicare shared savings programs, bundled payment initiatives, all of those kinds of efforts to bring different providers together to provide managed and coordinated care for a certain population of beneficiaries. It's so important that we work together. And if you look on our website at some of the proceedings that have occurred on exploring ACOs, you'll see documents not only from OIG, but from CMS, from the IRS, from the Federal Trade Commission, the FTC, from the Justice Department. There are many pieces that are affected, many pieces of the law and many parts of the healthcare landscape that are affected by this notion of a more coordinated effort. Within OIG itself, of course, we put a premium on working with our partners in the federal community. We've talked about this in institutes past, that over the last several years, our office and our anti-fraud efforts, the so-called HEAT initiative, have worked with CMS and with the Justice Department to shut down all kinds of fraud schemes, whether it's infusion therapy or DME or home health. You know, significant criminal enterprises going on in some of the hot spots like South Florida, Houston, Los Angeles, and so forth. we can't possibly get as much done as we have with our HEAT initiative if we really weren't working effectively, hand in glove, with our law enforcement partners. And on the technological side, it's very encouraging to see the kind of partnership that is now developing between the government and between private insurers through the Healthcare Fraud Prevention Partnership, which is an effort underway this last year and a half to use data in a way that will allow us to identify common fraud schemes that exist both on the public and the private payer side. This is something that was envisioned years ago in the HIPAA law of the mid-1990s, but really only in the last several years have we really developed at this point the technological sophistication to protect data that needs to be protected either from a government or a proprietary perspective, and be able to examine common coding issues, common ways of false billing that allow for a far more robust public-private exchange. So coordinated care, and that's what all of these SHIPs is about, is really designed to re-emphasize, if it needs it, that we really need to be working across disciplines, across agencies, towards that common destination. I want to focus on some of the specific initiatives that we have at OIG. I think of our work really as trying to help direct industry towards making the most effective use of its resources so that we can move forward in the right direction. And that tugboat I think of as the OIG tugboat, trying to assist the larger healthcare enterprise. The issue that comes to mind with this slide is our hospital compliance audits, which we've had in effect now since about 2010. We've looked at close to 80 hospitals. We've been able to recover about $34 million over those years as a result of these audits, looking at common coding issues, transfers from acute to post-acute facilities, seeing where those issues are most common, and really being able to assist hospitals get these very important compliance issues right. We've gotten a lot of very positive feedback from a number of institutions that it's really helped be able to refine their capacity. We expect to do another about 25 over the course of the next year. And I do think that this way of doing business, of being able to look across different lines of activity, is something that has such value from a systemic standpoint that with technological advances, we need to try to do the same in Part B services. So without being able to get very specific with you now, I do hope that we'll be able to move to transfer a lot of the benefits that we've seen with our hospital compliance reviews to that very large piece of the action called Part B, and to be able to do some of the kind of data mining that we think will be very helpful. New just in the last couple of weeks is OIG's updated self-disclosure protocol. I have a slide here that shows a life preserver. I do think that this is really an initiative that's designed to help providers help themselves. I can't emphasize enough how valuable it is to engage in self-policing. And we know as a community that the most common things that are likely to arise, false billing, kickback issues, employing excluded individuals, those are the kinds of things that most often result in possible fraudulent conduct. This needs to be identified, disclosed, and resolved. We've been doing a self-disclosure protocol initiative now for a decade and a half. It goes back to 1998. And we're very committed as an office to continue to improve the process, to make it more user-friendly. There's a terrific podcast actually on our website by Tony Maida that kind of walks through how the SDP works and can be most effectively utilized. I would encourage you to spend at least a few minutes with it. I know there's been already some sessions devoted to it. I actually found, as I was coming in this morning, hard copies of our self-disclosure protocol around our seat. So I think there are even extra copies of the hard copy itself that just came out on April 17th. I would encourage you to take a look at it, to be familiar with it. We have a lot of good informational materials about it on our website. Take advantage of it. Keeping watch. This slide is designed to emphasize that as opposed to throwing heat, which we talked about a few minutes ago with respect to criminal enterprises, the so-called pirate problem that we have in healthcare, we also try to throw light on the laws and the authorities that we have so that you have a full understanding of how OIG goes about overseeing the field and how you can be most effective in understanding what your responsibilities are. So again, look at the website to see our very helpful podcasts, an explanation of the False Claims Act, of the anti-kickback statute, of what the civil monetary penalties law is about, of how exclusions work, and in that respect, if you want a good sense of how the LEIE operates, I would encourage you to take a look at Andrea Berlin's podcast on our website. There's really good stuff on exclusions, and there'll be more on it, by the way, shortly when we issue our special advisory bulletin that's expected to issue soon. And worthwhile material along with CMS on the Stark Law. Our lighthouse is designed to throw light so that there are no shipwrecks, that we avoid the problems that arise as a result of sheer ignorance of the law, of not knowing what's required. Corporate integrity agreements, I emphasize self-disclosure protocols because to the extent that we can self-police effectively, we find ourselves less involved in having to design corporate integrity agreements for those who have found themselves in very dangerous waters, have got kind of beyond the boundaries, and we need to assist in being able to channel behavior. Corporate integrity agreements have been around for a while now. They have actually great potential to help providers come up with model compliance programs, and there's been feedback, honestly, from the pharmaceutical industry, from skilled nursing facilities, about how working with CIAs have actually improved their operations, and that they are they're very pleased. They're very happy with the ability to be able to follow a set of guidelines and directions that result in a far more robust and effective compliance environment. So those buoys that you see are just a reminder that when necessary, there are corporate integrity agreements that, as a result of settlements of cases, will allow us to stay channeled and are very, very valuable. This is a screen that shows sharks. Another recent OIG development is the publication of a special fraud alert on physician-owned distributorships. And this is an area where, because of exposure under the anti-kickback statute, potentially for ambulatory surgery centers and hospitals, it would be extremely important to take advantage of our special fraud alert, read it with care, understand that Physician-owned distributorships, known as pods, are inherently suspect, and that because of the potential AKS liability for hospitals and for surgery centers, it really is important to look very, very carefully at whether these kinds of arrangements serve the healthcare provider or not. So keep in mind the shark-infested waters. For years, I wanted to show you what a safe harbor looks like. I don't know if this is a safe harbor or not. I hope it is, for somebody, for something. But this is a reminder that we have also issued a very important publication on extending the current electronic health record safe harbor under the kickback statute. Right now, what we published back in 2006 is scheduled to expire at the end of the year. It really is a testament to how things have, take time, have evolved over the years, that the original publication went back now 7-8 years. And now we're at a somewhat different place, but we're still looking to see how we can ensure that providers can receive, that there can be a donation of electronic health records that will continue to promote interoperability, that will move us forward on our national healthcare information technology platform. And we want to make sure that we get these provisions right. We want to make sure that we're covering the right folks for the right reasons. So please take a close look at what has been published. Comments are due by early June, so we're still in the comment period, but we're looking to extend the safe harbor. And safe harbors, as you know, are very, very important under the kickback statute, and I think reveal a very, very important philosophy about trying to advance as much as possible an effective, cooperative information technology environment for healthcare. Which brings me to data, technology, and electronic health records. Technology is really remarkable. I've heard it said that computers exist for the amplification of human intelligence and human capability. Unfortunately, they also exist for the amplification of human error and sometimes human malice. So we need to be very careful how we deal with technology. But indeed, this is so much transforming our field. I have heard big data described by one academic as moving from the mass application of individual data to the individual application of mass information. We're really drilling down on the ability to take masses of information and be able to custom work that kind of data in ways that were unimaginable in the 20th century. So indeed, data, technology, and EHRs are very much the future. I've got I think a radar screen up there. It's a reminder that when it comes to maritime navigation, it took quite a while to get it right. About the time the Titanic sank, sonar, which stands for sound navigation and ranging, was just getting underway. Sonar was actually patented about a year after the Titanic sank. So we're talking about World War I. It took until about World War II, 1940, before radar, which is known as radio wave detection and ranging, actually got up to speed. So we're talking about a significant time lag. Indeed, when it comes to data technology and EHRs, there are time lags as well. We need to be patient about the evolution of technology, but impatient to apply it as quickly as possible and as effectively as possible. And OIG, along with other government partners, are trying to work effectively with our private community to make sure that we do this as seamlessly as possible. It is a big job. It is a very important compliance job. in large part. And compliance does check the direction that we're going. You play a critical part in all of this, and I very, very much enjoy and appreciate the opportunity to come every year and talk to you about how very, very valuable this is. Because I don't know whether anything I've said this morning is going to reduce anyone's stress. But these are the things I do know. I do know that you perform very important work. You do it very well, and you should be very proud of the work that you do. I do know that many of you exert heroic efforts as key members of your management team. You know, American healthcare, like American law enforcement, has no shortage of heroes, as we witnessed in action in Boston last week. American healthcare is innovative and it is very strong. And you and I are very fortunate to occupy positions where we can make it stronger still. And with that, I leave you the maritime blessing of may you always enjoy fair seas, fair winds, and following seas. Thank you.